In clinical examination of the ulcer, palpation should be done with a gloved hand with other universal precautions to be followed. Inform the patient what is going to be done. Patient should always be examined on the examination table with the help of there should be good lighting. First, what you have to check is localized warmth and tenderness. It indicates signs of progressive inflammation. And palpate the ulcer edge for induration. It tells the chronicity of the ulcer. Floor should be palpated, and then base should be palpated. And there should be, if ulcer is very large, fixity of the base cannot be demonstrated, and even it is difficult in patients who are having ulcers over the bony prominence. In case if the ulcer is too deep or extending till the bone, an examiner should use a sterile swab stick or a forceps to probe and see the depth of the ulcer. Similarly, at this time, I always recommend to take a pus culture sensitivity during the examination itself. Why it is very important, because pus culture sensitivity tells you the colony of what type of organism that is affecting the diabetic foot. Even though initially the treatment for diabetic foot ulcer will be started with an empirical antibiotic, pus culture, based on the pus culture, the antibiotics should be changed accordingly. This slide shows a neuropathic ulcer located in the ball of the great toe and in the base of the first metatarsal head. It shows a well-defined margin, punched out edge, and a floor filled with pale granulation tissue. The second and the third image shows gangrenous changes in the foot. The third image shows the dry gangrene. The pulse examination is very important for a patient, irrespective of whether there is a gangrene or an ulcer, because the moment a gangrene has occurred in a diabetic foot, it indicates there is a presence of a peripheral vascular disease. To differentiate between a dry gangrene and a wet gangrene is important. Clinically, it can be identified by certain clinical features. A wet gangrene will be having no line of demarcation, and the toes will be swollen, and there will be blisters. On palpation, there will be crepitus due to gas-producing organism, and there will be discharge. Whereas a dry gangrene will be mummified, dry, and it will be having three separate zones. One is zone of demarcation, zone of separation, and zone of hyperemia. Apart from location of the ulcer, discharge, depth examination, and gangrenous changes, the most important part here is sensation of the foot and peripheral pulse examination and active and passive movements of the ankle and the lymph nodes. In diabetic patients who are having diabetic foot ulcer or neuropathic ulcer, the most common cause is predisposing factor is diabetic peripheral neuropathy. Two important pathways are involved here. One is involvement of the posterior column, and that is the nucleus of gracilis and nucleus of fasciculus gracilis and fasciculus cuneatus, and the spinothalamic tract. Both these tracts are important for vibration sense, touch and temperature. Of these, spinothalamic tract is involved in temperature and touch, and whereas posterior column is mostly for vibration sensation and crude touch. So a patient to examine the vibration sensation, it can be done easily at a bedside using a tuning fork. A normal human perception for vibration is between 200 to 300 Hz. Vibration below 100 Hz is not appreciable. If it is often mistaken that bone is having vibration receptors, which is not true. If the nerve endings, it is the nerve endings in the soft tissue over the bone that is responsible for that vibration sensation. Normally, the test is done using 128 Hz tuning fork. Rarely you can use 256 tuning hertz tuning fork. Normally the tuning fork vibration sense examination starts by placing the tuning fork on the distalmost phalanx of the toe, and then slowly it is progressed to the medial malleolus, then tibial tuberosity, and goes up to the sternum. Normally a patient should be able to perceive the vibrations up to 11 seconds. Any delayed vibration sensation indicates there is a posterior column involvement. Then Semes Weinstein monofilament test. This is for sensation in the foot. This picture shows pressure points where this filament has to be placed and tested. The box shows the types of filaments what is being kept here. Normally 10G monofilament is used for knowing the sensation. A patient who is not able to perceive 10 gauge monofilament indicates that the patient is having a peripheral neuropathy. The test is done by placing the monofilament exactly on the pressure points, and pressure is given approximately 2 seconds. If the patient is not able to perceive, that point is considered to be a point where there is neuropathic affected area. Biothesiometer is a device that is used to measure vibration sensation in the foot. If it has replaced that use of a tuning fork, it is little more specific. So it has been the biothesiometer usage is based on the grading. It tells you whether the patient is having a normal vibration perception or severe vibration perception based on the voltage perception that has been applied. If a patient is able to appreciate a voltage range between less than 15 at a frequency of 4 to 225 Hz, that means it is a normal study. Whereas a patient who has been given for more than 25 voltage range and is not able to perceive a vibration more than 625 Hz, that means it indicates severe vibratory sensation loss. Peripheral pulse examination in the foot. Peripheral pulse examination in the foot is the most important clinical examination. Without it, the examination of the foot is not complete. So what are the pulses in general we have to do? We have to examine. One is dorsalis pedis artery, posterior tibial artery, then popliteal artery, and then femoral artery. Dorsalis pedis artery is done by placing the examiner's hand lateral to the extensor hallucis longus tendon over the first web space. Peripheral pulses should always be examined simultaneously in both the foot to see the difference in the pulse. Then posterior tibial artery is palpated between the medial malleolus and tendo Achilles. Similarly, like how dorsalis pedis artery is felt, both the posterior tibial artery should be felt simultaneously. Popliteal artery should be examined either in prone or in supine position by giving a firm pressure on the tibial tuberosity or the femoral condyle to palpate the pulse. Femoral artery pulse is palpated by identifying the midpoint of the inguinal ligament, that is from the anterior superior iliac spine to the pubic tubercle. So the midpoint of the inguinal ligament corresponds to the femoral artery. Both the femoral artery pulses should be palpated together as shown in this image. Why peripheral artery pulses is very important? Because a patient who is having an absent pulse or a thickened arteries indicate there is an underlying peripheral arterial disease that tells the prognosis of the diabetic foot ulcer. Ankle brachial pressure index. Ankle brachial pressure index is used to know whether the limb which is being compromised will go in for land up in amputation or not, or whether this foot needs early revascularization or not. That is what is being decided using an ankle brachial pressure index. Ankle brachial pressure index is a non-invasive tool to assess the peripheral vascular disease. All you need is a blood pressure cuff with aneroid dial and also a Doppler, a handheld Doppler, which is about 8 to 12 Hertz. So how it is done? First, the blood pressure cuff is tied on the arm and the Doppler probe is placed on the brachial artery, and the pulse Doppler sensitizes the pulsation, and the blood pressure cuff is started raised. The pressure in the cuff is started raised and to a point where the Doppler signals stop. That will correspond to the brachial pressure. Similarly, a blood pressure cuff is tied in the ankle and Doppler probe is either placed on the anterior tibial vessel or posterior tibial vessel, and the blood pressure cuff pressures are raised till at a point where the pulse becomes absent. The pressure difference between these two is divided and the values are identified as given here. Any patient who is having an ankle brachial pressure index more than 1.4 includes it is non-occlusive due to non-compressible blood vessels. These patients has to undergo another test called toe pressure monitoring, and those patients who are having a ankle brachial index between 1.0 to 1.4 indicates normal peripheral arteries, and patients who are having less than 1.4 to 1.9 indicates borderline peripheral vascular disease involvement, which needs a vascular surgeon opinion to identify the other risk factors. Patients who are having values less than 0.9 indicates abnormal and diagnosis of peripheral vascular disease. Patients who are having ankle brachial index below less than 0.6 or 0.4 is suggestive of a critical limb ischemia. So any value ankle brachial pressure index below 0.4 indicates critical limb ischemia. That tells you that these patients with having diabetic foot ulcer can land up in amputation. Then segmental pressure test. Multiple blood pressure cuffs are tied at varying levels in the limb and pressure recordings are identified, and then based on the difference you can identify the level of stenosis. Normally, the pulse pattern in a Doppler is usually a triphasic pattern, whereas a patient who is having a peripheral arterial disease, it is mostly monophasic or absent. Toe pressure index. Toe pressure index is ideally it is a non-invasive time and cost-effective tool, and it has less time and cost-effective tool. It is measured using a small cuff that is tied to the toe along with a probe to measure the pulse using a Doppler. It measures the small artery pressure. Usually a patient with diabetic foot ulcer whose ankle brachial index is more than 1.3 to 1.4 are the candidates to undergo toe pressure index. Normally the toe pressure index in a healthy individual is between 70 to 90 millimeters of mercury. Diabetic foot ulcer patients for wound healing, the range must be between 30 to 70 millimeters of mercury. The toe pressure less than 30 or 40 is known to have increased the likelihood of a non-healing ulcer. So toe pressure index will also give an idea whether the foot ulcer is going to heal or not. A toe pressure index less than 0.7 is suggestive of a peripheral arterial disease. Duplex ultrasound. It is a combination of B mode and a Doppler ultrasound. It is highly sensitive and specific in detecting localized velocity information at stenotic sites. The normal arterial Doppler velocities are usually triphasic. In patient who is having peripheral arterial disease, it is usually biphasic or monophasic or sometimes absent also. If the image shows Doppler ultrasound showing a triphasic flow pattern. It's a normal triphasic flow pattern what you see in this image, whereas a patient who is having a peripheral arterial disease, this triphasic graph will be absent. It will be either monophasic or a flat line graph. This is the B mode ultrasound image. B mode is nothing but a grayscale, where the grayscale image seen on the ultrasound monitor, you can tell the depth, you can tell the size of the vessel plaques in the vessel, and also you can know the exact diameter of the vessel narrowing that can be identified using a B mode scan. The image on the right side shows the normal foot CT angiogram. Who requires CT angiogram? Diabetic foot ulcer patients who have been diagnosed to have peripheral vascular disease with other tests like ankle brachial pressure index, toe pressure index, and patients who are clinically presenting with gangrene or patients who are having clinically absent pulse, then those patients a CT angiogram is done, especially when it is needing for a revascularization procedures. So what are the advantages of doing a CT angiogram? CT angiogram gives a three-dimensional image of the vascular system in the lower limb. It not only tells the anatomy, it also tells the stenotic size, stenotic segment levels, and collaterals also can be easily identified by CT angiogram. It is done by using an intravenous contrast. The water-soluble iodinated contrast is used, and the patient, the most important part in doing a CT angiogram is the patient renal function should be normal and patient should be hydrated well prior to the test. It is highly specific and sensitive, ideally done before patients who are requiring only revascularization procedures. Charcot arthropathy. This is another known complication of a long-standing diabetic foot ulcer. The reason for this is The Charcot's foot is because of there is microvascular damage along peripheral neuropathy leading to improper weight bearing areas, causing multiple microfractures and macrofractures and healing, producing an altered shape of the foot called Charcot's foot. If you take an X-ray for a patient who is having a Charcot's foot, it looks like a consolidation of the foot in the X-ray. And this Charcot's foot has to be identified early because these patients can have abnormal pressure points, and these patients are known to have a midfoot ulceration. So Charcot's foot identification is also one of the important clinical examination. Is also one of the important part in clinical examination. Even though it affects only 1% of the patients with diabetes, but still it is important in managing the diabetic foot ulcer. Patients who are having a swollen toe with an open sinus with pus discharge or crepitus, then definitely X-ray foot is important. X-ray foot will show bony destruction, indicating that there is a presence of osteomyelitis. Once you come to a conclusion that what type of foot we are dealing with, then we have to stage the ulcer based on different classification systems. Wagner's classification is one of the commonly used classification. There are some limitations with that. It has 6 grades. Grade 0 to grade 3 mainly deals with the depth of the ulcer, whereas grade 4 and grade 5 mainly describes about the ischemic changes, that is ischemic changes in the foot. Whereas depth ischemia classification tells about the depth and the ischemia separately. It is a modified version of Wagner's classification. So the grade 0 means there is no break in the skin. That is the neuropathic ulcer, the early stage neuropathic patient with diabetes with neuropathy. Hardly you will see a callus formation, and there will be no break in the skin. Grade 1 ulcers are superficial ulcers. Grade 2 ulcers where bones, tendon, joints are exposed. Grade 3 are bone, there will be abscess or osteomyelitis in the ulcer base. So ischemia, grade A indicates no ischemia, grade B indicates ischemia with no gangrenous changes, grade C indicates partial foot gangrene, and grade D indicates complete gangrene. University of Texas classification, it is more simpler and more practical to use. They categorize the patients based on the ischemia and the infection. So they are staged into stage A, B, C, D, which includes stage A includes non-infectious or ischemia, stage B includes infection present, stage C is ischemia present, stage D is infection with ischemia present. Then grading of the ulcer is done by 4 grades: grade 0, grade 1, grade 2, and grade 3, which is similar to that of the Wagner scaling. Then another common system used is Wi-Fi wound classification system, which includes wound, ischemia, and foot infection. The grade 0 is the least grade what is followed, and grade 3 indicates severity of the diabetic foot. How it is important in managing diabetic foot ulcer? There is in Wi-Fi wound classification system, the wound shows 4 grades: 0, 1, 2, and 3. 0 is showing no ulcer or no gangrenous changes, whereas in grade 3 it shows extensive deep ulceration in the foot, or there is extensive gangrene involvement in the midfoot or heel necrosis. Whereas ischemia grade shows grade 0 to grade 3. Ischemic based on the ankle brachial pressure index and toe pressure index. This grading has been done. So the patient who is having a toe pressure less than 30 millimeters of mercury or ankle brachial index less than 0.4 indicates suggestive of severe ischemia. Similarly, foot infection shows 0 to 3 grades. The 0 shows approximately no symptoms or signs of infection, whereas grade 3 shows sepsis features. This is important here. The advantage of wound ischemia foot infection classification system is it tells whether the infection is confined to the foot or it is having a systemic involvement. Grade 1 and grade 2 shows the foot infection is confined to the foot alone, whereas grade 3 shows there is a sepsis. Along systemic sepsis is also there. Management of the diabetic foot ulcer. Any patient who needs urgent treatment, who are at high risk, moderate risk, low risk, and very low risk, has to be categorized based on the American Diabetic Association criteria. Urgent treatment. Any patient who is having an open wound, ulcer with or without signs of infection, new neuropathic pain or pain at rest, severe Charcot's deformity, red swollen midfoot or ankle, vascular compromise. It is immediately the patient has to be referred to the center where diabetic foot is managed. High risk patients, presence of diabetes with previous history of ulcer or extremity amputation, chronic venous insufficiency. There should be immediate care should be given to these patients as outpatient basis at the specialized center, and they should be monitored every 1 to 2 months. Next, moderate risk patients are otherwise called risk category 2, patients who are having peripheral arterial disease with or without loss of protective sensation. Though the dorsal pedis posterior tibial arteries are diminished, but there will be presence of swelling and edema. These patients referral occurs within 1 to 3 weeks. After that, they should be on regular follow-up for every 2 to 3 months. And then low risk category or category 1, where these patients are having loss of protective sensation and long-standing non-changing deformities. Patients requires prescriptive or accommodative footwear. They are referred within 1 month duration to the specialist, and they should be followed up once in every 4 to 6 months. Very low risk category indicates these patients who are having no loss of protective sensation or peripheral arterial disease. These patients should be educated very well how to manage the foot in the routine care, athletic training, and how to choose the appropriate footwear and how to prevent the injury. Referral, these patients should be referred to the specialist within 1 to 3 months time, and they should be on periodic annual follow-up along with diabetic checkup.